Welcome to Department of Medicine Grand Rounds. This week's Grand Rounds is the Gordon Meiklejohn Memorial Grand Rounds. You can see Dr. Meiklejohn's picture on the slides, hopefully right. Dr. Meiklejohn is basically the founding department chair of the modern Department of Medicine. He was recruited to Colorado from California in 1951. Colorado at the time was a tiny, underfunded medical school. He took a pay cut to move here and led a faculty that you could have fitted the entire faculty into a single patient exam room. Over the course of the 25 years that he served, he grew our faculty about 100-fold. There were exactly 0 research programs in the department when he arrived, and he put Colorado on the map nationally and internationally. He himself was a pioneer in flu vaccination, pneumonia vaccination, and played a major role in the eradication of smallpox. He was an Olympic class hockey player and played tennis till late in his life and was still attending Grand Rounds regularly when I was here as an intern a number of years ago. So just to call out the debt we all owe to Dr. Meiklejohn in building the department that we now call home. I think Dr. Meiklejohn would be delighted by the speaker we have today, Dr. Sandra Springer, who is a professor at Yale University and an infectious disease expert herself. Her expertise and interest is really in I'm not sure what the term of art is, the twindemics, the syndemics of infectious disease and addiction, and looking for novel and innovative ways to combat the two. She began her academic career at Harvard, where she achieved her bachelor's degree, got her MD degree from University of Massachusetts after trying a few other things out on the way. Became a resident at Yale and completed her ID fellowship at Yale and has stayed on faculty there. She works at the VA as a VA doc, and has a real interest, which I hope she'll talk about, in mobile healthcare. She has been funded continually by the NIH for nearly 20 years, including an Avant-Garde Award from NIDA, which she for her innovative work at the intersection of HIV care and substance use disorder treatment. She's currently appointed to the International AIDS Society and the USA Antiretroviral Guideline Panel. She's had a couple of different appointments to the National Academies of Sciences, Engineering, and Medicine, including serving on the Committee on the Integration of Opioid Use Disorder and Infectious Disease Treatment, and more recently, the Committee on Conditions Among Women, and is also appointed to the American Society of Addiction Medicine's Criminal Justice Guideline Committee. She's a mother of 3 children, an avid foodie, an outdoors enthusiast, a former collegiate basketball player, and an all-around delightful human being. And we are so thrilled to have you here and looking forward to what you have to say, Dr. Springer.
I don't know if this. Thank you. Well, thank you for that really kind introduction, and it really is an honor to be here. It's just outstanding, and a lot of really good friends and colleagues here, and the new individuals I've met that are doing like outstanding work. So thank you for inviting me. So I'm going to talk today about predominantly how we're trying to improve access to services for people in the community, really utilizing mobile health services. And I'm going to hopefully, the work that I discuss, although you may not be doing specifically substance use or infectious disease, the whole idea is that these services are for whole person healthcare and really trying to overcome barriers for individuals who may have difficulty accessing our typical healthcare system. These are my disclosures. The learning objectives are here. I'm not going to read through them, but really just coming away with hopefully you understand the current epidemiology in the United States of substance use and infectious diseases, and really understanding the need for us to improve access to services, potentially through integrated mechanisms, not just in our hospital settings, our community settings, carceral settings, and then come away with some ideas of mobile healthcare systems that include partnerships with pharmacists, community healthcare workers, and others, and not just around substance use and addiction, or infectious disease, but also other care. So let's just start with the question of why even think about bringing, say, medical treatment to people where they live, not even talking about addiction or substance use disorder just yet. So let's start with a clinical case. A 45-year-old woman who's had hypertension, diabetes, recently hospitalized with an acute MI and found to have new heart failure. You do, you're a medical student, or you do an excellent history, and you find out that she's been having difficulty taking the medications that have been prescribed for these conditions. And she includes reasons as working 2 jobs and a single parent. She reported it was difficult for her to get to medical appointments. So medical appointments are typically during her working hours, and her employer wasn't really giving her the time to take that off, had difficulty with transportation. And she'd also been reported as multiple no-shows if you looked in your Epic system, but not really that you could see any notes identifying maybe why she was having a hard time. She also stated to you that she had a difficult time getting to her pharmacy. Co-pays were high for the medications that she was prescribed, and she didn't understand some of the instructions. So she'd had some adherence issues. Now you're telling her you're going to have to start some new medications for this identified new heart failure, and she's a little worried about that. So is there something we could do to help her in this situation? So as I'm going to discuss why we should consider even changing our healthcare system to make it easier for patients to receive the treatment they need. So this is a quote from my friend Carlos Del Rio when we were at a National Academy meeting one day. And I don't know if it was his quote or if he was quoting somebody else, but he always has quotes. And one of the things was, he said, we know when a restaurant's failing, do we ask why people aren't coming to the restaurant? No, we say that there's something wrong with the restaurant. So why do we in the healthcare system say there's something wrong with the patient? Why aren't they getting to our brick and mortar clinics, our typical medical appointments? And why can't we switch it and say, what's wrong with our healthcare system? So let's take that same case, now add on, she has opioid use disorder. She has HIV, and you find out she's unhoused. Why do we in the healthcare system have a difference in how we approach a patient who has these underlying conditions? Opioid use disorder, lack of housing are all conditions that deserve the same discussion and attention on how we can help people receive the care for hypertension, for diabetes, as well as for HIV. And untreated substance use and lack of assessment of the other social needs really are going to affect that treatment. So what I'm advocating for, and it's not just me, is this idea of whole person healthcare delivery. So these are a lot of barriers, and these are in Connecticut, where I'm from, and with multiple other individuals and other organizations and other states that we see. But lack of transportation is a real issue, even in urban settings. In Connecticut, we have a non-existent public transportation system. There might be in the little cities of New Haven and Hartford some bus systems, but outside of that, really not. And even in a setting where there might be a bus system, it might be difficult to access that. Housing instability, as you all know, can definitely interfere with access to medical care, but also, as I'll show, accessing medications in pharmacies. So an individual who's unhoused, if you ask them, it's really difficult for them to leave their belongings to go to a pharmacy, to go to a healthcare setting, worried about them being removed. Poverty goes without saying. Lack of insurance, of course, Colorado, Connecticut, Medicaid expansion states, but still we have issues of people navigating that and uninsured. Lack of form of personal identification. I don't know how many know this, but in many states, including mine, you need us to show a form of ID. If you're going to go get your blood drawn, say at Quest Labs, you might be able to have no problem here in your healthcare center. But when you start going out, when there's phlebotomy services may not be in an academic setting, it's really difficult. Also, you need a form of personal identification if you're going to go to a methadone program to receive your methadone. Mental illness, either untreated or potentially treated, can interfere. Lack of ability to find a pharmacy, or the pharmacy may not stock the medications. There could be substantial copays, and pharmacists may not want to dispense a medication to you. And that's actually a real issue. And the stigma, we can't go without saying stigma. Stigma in the community, stigma from us, from the healthcare provider, a lot of bias, and then difficulty identifying where to go, what to do first. Just think about it. How do I get an ID? Where do I go? If I don't have transportation, I'm unhoused. And so there's a lot going on that can affect an individual's access to healthcare. So now I'm going to switch and talk about what I do, which is providing integrated substance use and HIV prevention and treatment to people where they live. But think about it from the same point of view as what I started out with, bringing whole person healthcare. Maybe for me, it might be improving the access to substance use and HIV prevention treatment, but without really focusing or trying to figure out who is that one person that I should be talking to. We should really be offering these services to everybody. So the problem, I think you all know, substance use is an epidemic, and the overdose epidemic in this country. It's not really abating, despite what the CDC just reported this week, reportedly saying there's been a downtick in overdoses. That's not necessarily true. If you look at certain states like Colorado, actually overdose deaths are going up in stimulants and other areas, but and a lot are underreported, and there's a lot of other substances like xylazine, benzodiazepines, et cetera, that are causing overdose deaths. But fentanyl is a main drug of main cause. Illicitly manufactured fentanyl is really driving that. If people are saying they're getting heroin, it's probably not heroin. Heroin is actually decreased. It's really tough to find heroin, and that was a black tar heroin coming from Mexico. Prescriptions, opioids, not the major issue. And methadone, despite what people say, is not causing increased overdose deaths. Stimulants, though, on their own and in conjunction with opioids and other substances are also driving a lot of overdose deaths. So in your neck of the woods, methamphetamine. In my neck of the woods is cocaine, cocaine, cocaine. And those in combination are causing a lot of deaths. And although, like I said, there could be a slight downtick, it's not really decreasing in many areas of the country. It's not happening in a vacuum. Substance use and substance use disorders, it's not, although there's significant morbidity and mortality related to that, it's also driving other chronic conditions and new problems like infectious diseases, but also improving or increasing, cardiovascular mortality, liver, and other problems. But from an infectious disease standpoint, this is older data, but we do know, because I know a lot of you are in the hospital setting, that opioid misuse, or what we used to call dependence, it was driving increases in serious injection-related infections, infectious endocarditis, leading to a doubling of hospitalizations right when the black tar heroin was coming up. And now we're still seeing that in New Haven, a lot of infections related to injection drug use. Hepatitis C, and of course, HIV. So since our early HIV epidemic, we were able to make improvements with Ryan White Care Act, syringe services, expansion of methadone, all of that really reduced new cases of HIV in people who are using drugs. But since 2015 in Scott County, Indiana, which you're familiar with, we've started to see more and more outbreaks occurring among people who are using drugs, not just injecting drugs. Scott County, as you know, was related to oxymorphone and a prescription opioid in a really rural area, lack of transportation, a state that didn't have Medicaid, a governor who refused to expand syringe services and methadone programs. So it's kind of a coalescing storm that was happening. But since that time, multiple states, including Medicaid and non-Medicaid expansion states, are seeing new HIV outbreaks. And so people aren't really getting access to services. And that could be harm reduction services. It could be substance use treatment like medications for opioid use disorder, as well as HIV prevention treatment. So for HIV, we don't have a cure yet. Our goal is to start antiretroviral therapy as soon as possible and achieve viral suppression. That's less than 200 copies per milliliter. That improves the individual's health and improves and allows their immune system to improve and augment and reduce the likelihood of acquiring conditions related to AIDS. But also from a public health standpoint, we know that if an individual does not have a detectable viral load, so viral suppression, they cannot transmit HIV to an uninfected person, regardless of condomless sexual intercourse or sharing injection drug use. So the U equals U, undetectable equals untransmittable campaign, that's well known. So we want our patients with HIV to be identified, get them on treatment, and retain on treatment. They need the medications. All forms of substance use actually are well known to obviously increase the risk of acquiring HIV. but also among those who have HIV, substance use ongoing can interfere with that HIV care cascade, so interfere with adherence to antiretroviral therapy, and then that leads to increases in viral load, and then, of course, potential from increased morbidity to the individual, but also a public health standpoint, increasing HIV infection. So my formative work, early work, had all been about how to integrate medication treatments for opioid and alcohol use disorder to improve the likelihood of achieving and maintaining viral suppression. And those were shown in prospective trials, including double-blind placebo-controlled trials, with this idea that if we could integrate substance use disorder medication treatment with HIV treatment, we could improve that goal. So medication treatment for substance use disorder as treatment as prevention. No matter how many clinical trials you do, the main issues are, do people have access to those medications and can they maintain? And we know that all clinical trials say for medication treatment for opioid use disorder, less than 50% are retaining on those medications despite how effective they are at about 6 months or 12 months. And the similar aspects we'll talk about for pre-exposure prophylaxis, et cetera. So this is our United States ending the HIV epidemic plan that you're probably familiar with, grounded in a lot of science. So we are it's all to reduce HIV incidence. So diagnose all persons with HIV, get them into treatment rapidly. So same day, as soon as you have a rapid HIV test, you don't have to wait for viral load, initiate medications, retain. They don't have HIV, prevent with either prescribing prescribing pre-exposure prophylaxis. So we have 3 FDA-approved medications, 2 oral, 1 injectable, all reduce HIV incidence, and also syringe services for those who inject drugs. And then the 4th pillar put out by our Department of Health and Human Service is to respond quickly, know where the outbreaks are going to occur, all to reduce incidence by 90%, which was supposed to be in 2030. But it didn't include implementation plans and didn't include integration of substance use disorder. So we're not on target to reach our goals. We're supposed to be down to 9,000 infections by next year. And although the CDC data lags, we had about 32,000 new infections in the United States a couple of years ago. So why isn't it working? Well, for persons who use substances, but also other individuals who might have access to difficulty access to services, we've been thinking about this as we expect people to know where to go to get access to services. For, say, HIV, know where to go to get tested, know where to go to get PrEP, know where to go to get antiretroviral therapy, then go somewhere else to get your substance use disorder treatment, somewhere else to get your harm reduction services like syringe service programs. We really haven't asked why patients are having a difficult time getting access to those integrated services. So what's missing? And again, that's coming back to what I'm trying to discuss is this ability to deliver a healthcare to individuals. So I'm just going to give you a case and just to show you Connecticut, if you're not familiar with it. It's a small state, but here's an individual who was in one of our typical randomized controlled trials coming out of prison and jail. She was coming out of York Correctional, which is in New London. Her house is, oops, I used the wrong arrow. Her house where she lives is up in a rural community called in Putnam. A car ride would be 1 hour. She doesn't have a car, but all of our patients get peer navigator. So that peer navigator could help her get there. If she had to take a bus, she would have had to take multiple buses. It would have taken 8 hours for her to get there. I'm telling you, this is just a small state, but it's really difficult. Now she wants to go to her primary care doctor. She's got high blood pressure. She's got diabetes. She needs to get seen to get refills. She also wants to discuss PrEP. That's another 45-minute car ride. The closest primary care provider is in Willimantic. Not only that, she was started on methadone, which was awesome in the York Correctional Facility. Great. So, but guess what? The only methadone program was in Hartford, the closest one that she could access. So that's another hour car ride. Both buses, I don't even know how long it would take. So she had to get there to get her next dose of methadone, right? You need that daily. When she got there, she didn't have a form of personal identification, which is very common in our population. Her ID was with her effects where she had been processed, where she had been arrested back in New Haven. So the methadone program was already de-escalating her dose. She was starting to go into withdrawal. And of course, she would have had to use an increased risk of death. But our peer navigator was able to communicate with the Department of Corrections, get her ID fax there so that she could keep going. But that's just one person. And we really just expecting them to just put your Just think about the patient with the hypertension and diabetes. If she lives out in this rural community, how's she going to get to see you? So we've been working a lot on how to overcome some of those barriers and bringing integrated care services to people where they live. This is one of our mobile health units. It has 2 exam rooms, a bathroom, a community health worker, and a clinician. And they literally drive to wherever people live. So if they're unhoused up in that area in Northeast Corridor, go to them, bring them their services or wherever. So this is, we're looking at the, oh, my screen just went black, but we're looking at the 2 systems, a patient navigator or a mobile health unit that could potentially improve your access to services. So the patient navigator is your own individual person who helps you and brings you to all your brick and mortar clinics. And a mobile health unit has the community health worker and the clinician in a one-stop shop. And the goal is, it's a NIDA-funded trial, a Justice Opioid Initiative study, where we're trying to help improve access to services for individuals who have justice involvement with stimulant opioid use and at risk for HIV or living with HIV, get access to PrEP, pre-exposure prophylaxis or antiretroviral therapy, as well as opioid use disorder treatment. We do rapid STI testing and hepatitis C testing, and also naloxone distribution. This is the classic design. It's a type 1 hybrid effectiveness implementation trial. We're in Texas, and Connecticut did that purposely because I wanted to evaluate a Medicaid expansion state and a non-Medicaid expansion state so we can really evaluate barriers and what could work and what isn't working. Individuals are randomized 1-to-1, and then the intervention 6 months, and we have a 12-month follow-up, and we're doing an implementation assessment the whole time. So differences, obviously size, although Texas looks small compared to Connecticut right now. Connecticut, we're in 6 of the 8 counties in the blue stars. Texas, we're in Dallas and Fort Worth. There's obvious differences, right? We're more rural and urban. Texas is in 2 urban sites. Fentanyl everywhere, but their main stimulant is methamphetamine. Our main stimulant is cocaine. And obviously the huge issues are Connecticut, a Medicaid expansion state, Texas, a non-Medicaid expansion state. So when we're thinking about access to services, this is going to be important. Harm reduction certain services legal in Connecticut, illegal in Texas. Remember those pillars, right? Those ending the HIV epidemic pillars, supposed to be for every single person in every state. One of the pillars was that you have to be able to provide antiretroviral therapy and PrEP and syringe services to individuals who need them. We provide all these services. So, you know, with the patient navigator supposed to link you to a clinician in the community that can access, or a service that can access that. And on the mobile health unit, we have community health workers who are helping you overcome barriers such as housing and other issues, as well as the clinician who can prescribe all medications for hepatitis C, bacterial STIs, do vaccinations, and importantly, PrEP and antiretroviral therapy and medications for opioid use disorder, and help with all those other services. So these are some of the other mobile health units. So Tarrant County with TCU, you see the purple one, that's their color. We also partner with one that was established in Dallas for many years, Homes Project, and they provide integrated services in Dallas. And so a couple new ones and one established. The trial is continuing. We have about 500 participants already enrolled and a lot of unique data. But I just wanted to share some things from this that I've learned and then informed the concept that I'm going to show you next. So one of the things is we think as a clinician or others that that my patients' potential risk for HIV, that they understand what their risk is, and it may be very different. And we have to really listen to patients. And then that might help us do more education, motivational interviewing, or just be available for them, maybe as that changes education. But this is just some baseline data from that action study that I'm showing you. The first 360 individuals, remember, we do rapid HIV, Hep C, STI testing. So the majority don't have HIV, so but they are at risk. They all had to be at risk or living with HIV. So hepatitis C, about 12% were preliminary positive and 13% had previous hepatitis C. Although this isn't showing you our baseline STI testing, they were reporting at baseline a history of gonorrhea, chlamydia, syphilis, and those percentages. And then when we looked, we do detailed risk behaviors, condomless sexual intercourse, sharing injection drug use equipment, prior STIs, overall risk in blue, orange is condomless sexual intercourse, gray is bacteria, recent STI, and in yellow is sharing injection drug use equipment. Overall, if you look, there's a high, over 80% risk behaviors that were happening. But then we asked their perception of whether they were at risk. And you see on the x-axis, the majority felt they were not at risk. So these are all individuals, all have opioid and stimulant histories, all already identified as at risk for HIV and coming out of a carceral system or involved in the criminal justice system. So we have work to do. That data was just published a few months ago in Emerging Infectious Disease. So in addition to understanding what our patients' perceptions are, we also have to understand what their needs are. And if we want to see uptake of whatever it is, biomedical intervention, it could be you want them to take their blood pressure medicine, you want them to do a better job of taking their insulin for their diabetes management, or we need to understand people's needs, and we need to meet people where they're at and try to help them. Because if you don't, they're going to have a really hard time taking those particular medications or whatever services that you want them to do. So we do a really in-depth needs assessment for everybody at baseline. And then the patient navigators work with the individuals to overcome those needs, as well as, you know, let's see if you would like PrEP or, you know, substance use treatment. And then they follow them over time. So I'm just showing you, this is Texas in red, Connecticut in blue. I don't know why I chose those colors, but you know, these are their medical needs. And I want to show similarities. So Connecticut, everybody really asking for medical care, dental care, mental health care, really, really important. Obviously, Texas more interest in need health insurance than Connecticut, not a Medicaid state. But for, say, opioid use disorder, medication treatments for opioid use disorder, that need is lower. And definitely for PrEP, less need, right? When we look at other socioeconomic needs, again, similarities. High degree of housing, both states, 82%, 71%, transportation, a major issue. And then similarly, that form of ID, over 50% didn't have a form of ID. And remember, you need that to access services, and a lack of communication, meaning a lack of a cell phone. So how do you actually even communicate with everybody or, you know, get appointments? So these are real issues. That day, like I said, we're still completing that trial, and we'll have more data later. But I think one of the things really working at is this patient choice and shared decision-making, when there's lots of evidence to support that that's helpful, but importantly for improving access to services. And for me, it might be medications for opioid use disorder, PrEP, HIV, hepatitis C treatment, but everything else. What do they want? Where do they want to receive it? How do they want to receive it? Really critical. We don't do that. We really don't do that enough. But it does improve likelihood of them being receptive. And if I had time, I would show you this most amazing study that was just done, was presented at CROI in Denver a couple of months ago, of individuals in Uganda and Kenya when they did this dynamic choice, and it was superb, and over 1,000 individuals. And the group that got dynamic choice, nobody developed HIV. And of the group that was the typical way you would do things, we had seven new HIV cases in that group. So we incorporate patient choice, we bring the services and treatment to them. So this is just showing some preliminary data from that action trial, and I'm not showing the Texas group, talking about Connecticut. So 100 were randomized to the mobile health unit, 19 were interested in PrEP. Anyone who's interested in PrEP, it's a win for me. And when we asked what would prefer, the majority wanted this injectable form. And I think a lot of us think, oh, people won't want an injection, and they do. Then we look at the demographics of that population, very similar to the overall demographics, nothing's really different. And then when you ask them, were you ever offered pre-exposure prophylaxis to prevent HIV before your justice experience or during your justice experience? 0. And then of those who were interested and received after our intervention, this is just preliminary, 11 did, and the majority were female. and the majority wanted injectable and received injectable PrEP. Time to initiate oral PrEP, 0. Just give them prescription. You don't need to wait for any lab data. You can do rapid PrEP. Our community health worker could help them fill that in the pharmacy, get it the same day. Injectable PrEP, we found out quickly, and again, it informed the next intervention that I'm going to show you, is a lot of pharmacies don't carry it. It's cabotegravir. It has to be dispensed in a specialty pharmacy. You have to order it, do blood work. You need an HIV RNA first. Then you have to pick it up, give it the injection. And we were able to do that. We do that on the mobile health unit, but it took about 9 days to do that. And I don't like that. I mean, we're supposed to rapidly, right, be able to do these services in any day without maybe access. What if it was treatment for opioid use disorder or whatever they wanted? Any day without it, potentially, especially for opioid use disorder, could be life-threatening. And this could be, we had a missed opportunity. Maybe they don't come back in the 90s. So when we think about bringing integrated care, it also includes bringing the medications. So the Avant-Garde Award was really just developing a mobile hub and spoke healthcare system, which included the pharmacy, the clinician, the phlebotomy, whatever you needed to do to assess, as well as potential for urine testing, so bathroom, and then the community health workers, absolutely instrumental. So individuals who are in the communities who can go to individuals who they might trust more to see, would they accept certain testing, also offer non-communicable disease testing, so blood pressure checks, finger blood glucose sticks, whatever it is, anything like that. And then if they needed and wanted to see a clinician, how would you like to do that? So they have iPads that can bring up a telehealth clinician in the moment wherever they are. And then the clinician can actually send the electronic prescription, just like y'all do right now, to your CVS, Walgreens, to your university setting. It just goes to this pharmacy and it can be dispensed by the pharmacist to that patient, and the community health worker can help them receive it. And and then there's a nurse available to draw blood, and also continue fostering retention with the community health workers and the clinician and pharmacist. And the whole idea is to overcome all those barriers so that we can help people get access to care. But the first question is how do you even know where to go, right? You don't want to send all these services to a place where they already have services and there's no need. So this is a real issue. We are looking at, obviously modeling, prediction modeling, but right to start out with, we went with who might know some of this. And so that's our Department of Public Health. They already have detailed data about, say, overdoses, HIV and hepatitis C and other issues, and they know that what services are available. So really did a boots on the ground assessing where should we go? What are the services? Who should we talk to? So we met with the mayor, we met with the law enforcement, we met with harm reduction services. We went out with the Department of Public Health individuals who are going out into encampments so that they would trust us, and really talking to the people. What do they want? So Waterbury, we chose Waterbury. It's in this, is one of the top 3 towns in Connecticut that was experiencing overdose. And so in 2023, over 700 visits per 100,000 residents occurring. There was New Haven and Hartford. We chose Waterbury. The Department of Public Health thought that was a good idea because although there might have been services available, they knew people weren't getting access to those services. And then understand what people want. So the next step is, I don't know. I mean, I have an idea, but we don't really know. And so we need to talk to people. So we didn't just go in there. We went around and did a brief survey of about 170 and 60 individuals, really different areas. So encampments, individuals who might have been accessing FQHCs, others, and asked them, would they accept free health screens? Would they accept it? 83% said yes. And then we said, how? How would you like to receive this? Would you like to receive an HIV test that you do on your own? Self-testing, right? That's being promoted. Great idea. A lot of people didn't want that. We asked, what about if we could have our community health worker provide a rapid test? Would you like that? The majority, 57%, said they would. So test result comes back in 15 minutes. The other was bring them to the mobile health clinic where a provider would do it, get a typical blood test, or another clinic, and less wanted that. Then we said, how would you like to see a clinician? So I assumed a lot of people wouldn't mind telehealth. We just lived through the COVID pandemic, right? We all had to do telehealth, but the majority didn't want telehealth. They said, no, they want to see somebody in person, which was challenging because it's hard to find a 100% clinician all the time that's going to be on the mobile health unit. But we had to have both in case there were individuals who didn't want to see somebody in person and wanted a telehealth. The other thing was understanding the barriers. So this isn't just me, and the reason why I'm doing this isn't just me saying this. There's a lot of data that's published that are showing that individuals have a difficult time going to pharmacies, even pharmacies that are right around the corner. And they were saying that there are a lot of pharmacies in Waterbury, and the main issues that are ranked by order were transportation issues, disability, copays, unhoused, not having the appropriate clothing, including no shoes to walk into the areas. And this is current, this is happening right now in a Medicaid expansion state. Wait times, distance to the pharmacy, not having insurance, renewal restrictions, too busy, too crowded. And just think about that. When you go to a pharmacy, what do you have to do? You got to provide your name and you got to say the name of the medication. And it's not, there could be a whole line of people. What if they don't have the medication? This happened to me with my son the other day. You know, you're like, where is the medication? Oh, we don't have it. We don't stock that medication. Or, and just think about other buprenorphine. There's quite a few pharmacies that, and that was just published in JAMA, that don't even stock buprenorphine. So you need to know that before you prescribe a medication. Difficulty reading the prescription, education barriers like our patient that I just described. So we said, if there was a mobile retail pharmacy that could come to you, would you use it? 90% said yes. So it was next was bringing this whole person healthcare hub and spoke system to people where they live. So it's challenging. So this is in motion. That's what we call it. But it's basically healthcare for everyone. You'll see on the side of it, it says healthcare for everyone down there. There's a 1833 number. The whole half of it is a retail pharmacy and a pharmacist, 100%, that's Heather. She dispenses all medications and can also do all vaccines as well. And community health workers who are out in the community doing blood pressure checks, finger blood glucose sticks, assessing other needs, rapid HIV, Hep C testing, substance use disorder assessments, helping with housing needs, transportation, insurance, et cetera. Clinicians, we have a full-time clinician and also partner with groups that want to do telehealth. And then they can importantly prescribe directly to the pharmacy, but you don't have to be on the unit or a telehealth clinician to prescribe. Anyone can prescribe. So working with hospitals, say you have a person who was discharged, you knew they were going to have a difficult time getting access to medication, or somebody who might have self-discharged and really needed help getting treatment. They can do everything. You can do dalbavancin, you could do infusions. There's a whole clinic that pops out. So a sickle cell group is asking us if we'll help them with getting access to patients who are living in that area needing iron infusions. All those things can be done. And then a mobile health technician who can do phlebotomy and financial navigation. And but as I said yesterday in general internal medicine, first and foremost, this was a big idea. After we got the award, I found out immediately, Sandy, you can't do that because retail pharmacies cannot become mobile unless you pass legislation, because it's illegal to take a pharmacy and put it on wheels, even though they already have their license. So that quickly led to, with our pharmacy partners and the Connecticut Department of Consumer Protection's Division of Drug Control, quickly drafting legislation, working with our government relations at Yale. I wrote most of it, and then we got Senator Maroney, to sponsor it. I provided public testimony, which was my first time, and you probably, more of you, like Josh and others, have been doing that, and I really think that's integral if you're going to do an intervention, that we're having more interaction with our government agencies. That then went through, passed through, and then as of July 1, our governor, Lamont, signed it, and as of July 1 of 2023, so 1 year later, mobile retail pharmacies were legalized. So SB 1102. Within that package, I also want to mention that I did not write. They also now allowed pharmacists to do HIV testing and dispense and prescribe PrEP and antiretroviral therapy. So really cool things that were happening. But I have to say, it still was difficult because then you have to overcome all the other issues. The pharmacy has to make sure it has the security services just like it does. You have to pass inspections. So as of December, we were finally able to get going with a little brief hiatus because Yale shuts down for the last 2 weeks of December and then hitting back up. But this shows you what the actual pharmacy looks like. It's actually a real pharmacy. Just think about any medication you guys want to prescribe, dispense there. It's also considered a specialty pharmacy, so it carries like cabotegravir or other specialty medications that you might not be able to get at brick and mortar pharmacies. And as I said, all vaccinations, we're going to be starting Mpox. You could do HPV, other things besides COVID, flu, tetanus, et cetera. So this is just remember this just recently started, so it's not a lot of people, but just wanted to show you some of the baseline characteristics. 48, mean age has been 48, the gender 34% identifying as female. In terms of insurance, most are on 58% are on Medicaid or other insurance, but about 40% were not insured, which is interesting. And then 29% identifying as Black, African American, 40% identifying as Latino. And then the housing status, I have more data, but I just asked them to do whether they were sheltered or unsheltered. And a majority there's good housing services or housing programs, but many were like in an area where they felt that they were sheltered. But this is, we'll divide this out a little bit more. Then looking at baseline characteristics, big one, 34% did not have a primary care provider. Another 10% did not disclose that. And then in terms of the last time they'd seen a non-emergency department provider, about 25% said over a year ago, 22% didn't know, so probably weren't. And then in HIV testing, 11% had never been tested before, another 14% were unknown, 22% had been in the last year. And I think it's important that 30% didn't want to disclose. And I think that's important. We have to earn trust. And so one of the thoughts is, it's not just one time, it's a dynamic program where we're going to be going back and will there be more, will they maybe more likely disclose and even accept testing? So just to show you the baseline screenings that the community health workers are doing, HIV, hepatitis C, finger blood glucose sticks, and blood pressure assessments. So those are the big big biological ones that they do. And then you can get other services if you want. We have, 37% accepted HIV. None were reactive. We had 2 that were already known to have HIV. And there's individuals, like I said, who are refusing. But as dynamic, we're going to be checking over time if maybe through providing healthcare services and other things, other needs, that might improve. Hepatitis C has been a big bonus. We found 10 reactive, and I'll show you data that it was a lovely moment where they were set when you tell them, oh, would you like Hep C treatment right now? And they say yes, and you're like, okay, you can have that. A lot of people accepted assessments for diabetes, and blood pressure was obviously the big one. They like that. And so we were able to identify quickly those who had elevated blood pressure, refer them to a clinician to reassess that. And we've identified quite a few with hypertension and diabetes. They also do substance use, not just screenings, but diagnoses through measures that we've developed and validated for opioid use disorder, stimulant use disorder, and then we use the audit for alcohol use disorder, and identifying those who might want treatment. And importantly, those who might report use, but may not want to go on to the further diagnosis. But I think that's important so we can help individuals know about potential services, provide naloxone, link them with syringe services, and we can also give them drug testing strips like xylazine and fentanyl. So we have over about 500 prescriptions that have been dispensed already from the mobile health unit, but just from the first 300, you can see of those conditions that we're assessing, the majority that reaching people for new hypertension or prior hypertension, diabetes, and vaccinations are definitely the big win. But also, for PrEP, alcohol use disorder, opioid use disorder. And then of this other category, just to show you this is whole person healthcare. A significant number for psychiatric conditions, pulmonary conditions, other infections like wound infections, tobacco use disorder, hypercholesterolemia, STIs, and we had one for a stimulant use disorder. So most of them are being actually dispensed from the pharmacy, but if there is a medication that we don't carry, the pharmacist quickly works with the local area pharmacies to get that medication and dispense it quickly, and the community health worker can help them get it so they get it the same day. The other part is for those so that, all this can be billed through insurance, but we also wanted to make sure those who were uninsured could have access to services. So partnering with Yale New Haven Health Pharmacy, as well as Yale, et cetera, we are able to do that. For medications, they have a philanthropic program called the Dispensary of Hope that carries and stocks pretty much every medication. It might not be the exact statin that you want, but something similar, and then can get them treatment. And importantly, even insulin, which is unfortunately so costly in this country, they can dispense it right there, and also PrEP, all the other medications too. So that's been really critical. I just wanted to briefly show you for Hep C testing, of the 10 that were reactive, 8 had wanted treatment, including 4 who had always wanted treatment. They knew they had hepatitis C and they couldn't get the medication, so it could dispense. And we do rapid hepatitis C treatment, just like we do with rapid HIV. So we do the antibody, we draw the viral load, we give them a short supply so that we can determine, so they can initiate, and then we retain them and come back and give them more medications if the viral load is detectable. HIV testing, like I said, none reactive yet, 2 prior diagnoses, but what was really interesting, they wanted long-acting antiretroviral therapy. So cabotegravir and rilpivirine injections is awesome, and they wanted that and they couldn't get that, but we were able to do that and start them. PrEP, 12 who are eligible, and immediately able to give them injectable PrEP, like when I told you before, that 9-day time period without having the pharmacy there, we were able to start in that moment, and also 7 oral. MOUD, medication treatments for opioid use disorder, alcohol use disorder, importantly, extended release naltrexone, starting in the moment. Many had never actually knew there was alcohol use disorder treatment. Again, they're small numbers, but we just started. So but it is very exciting for us. In terms of appointments, they can make planned appointments or walk up. We've had 200, more now, but at this time, 203 planned appointments, mostly medical services, although of course they can be seen for non-medical reasons, so social needs. And the appointments, predominantly, they want in-person appointments. So it's really important if you're going to be thinking of scale up that you have to have clinicians available. But we also offer phone and video if they need that. These are the purposes, mainly primary care services that are needed. So remember, providing whole person healthcare, but also psychiatric services and other specialty services. This is how we figured out how to let people know where we're going to be. So we've developed a QR code. And also a toll-free phone number, but if you were to put in the QR code, you can do it now if you want to, you would come, it looks like a web page, but it's actually a REDCap program, and it tells you what services are available in the calendar for about two weeks. We're going out to a month, and what you can have and where you will be. And you can actually, if you want, schedule an appointment, or your provider could schedule an appointment for you. And then we also have a little thing for providers on how you can actually prescribe, and also the pharmacist phone number, so you can call them. And that's been working out really well. So the pharmacist actually is communicating with the clinician. One big thing is not knowing that these medications cost so much money and big copays, so helping them navigate that. I'm going to probably end, but I just wanted to end with this case that just happened right before I flew out here, of a person who showed up to the unit, had schizophrenia, opioid use disorder, was actively withdrawing, had just bought some what he thought was heroin, but was likely fentanyl, was thinking he might get certain services from us. He didn't want to use it. And it turned out his wife had his medications in a box, including buprenorphine, and she had been hospitalized. So he didn't have access to those medications. So he was actively withdrawing from the buprenorphine that he was on. And so when he found out that there was a clinic, the clinician was able to see him, prescribe buprenorphine, start it right there, alleviate his withdrawal, and then they could work on making sure he had medications for his schizophrenia and his other services. So that was a big win. So I'll end there, my summary. Hopefully you come away with this is an important topic and we need to do more work at reaching patients. Implementation is absolutely critical. Every community is going to be different. Their needs are going to be different. And we need more precise targeting of where we're going to bring interventions. And that's the team, the Emotion team, and our driver right there with the awesome sunglasses. He's really good, Renee, and the whole Emotion team. A lot of people to thank, including the people, the patients, but also the funders, government agencies, partners, lots of multiple academic collaborators that have informed this work, people who supported the Avant-Garde Award, like Dr. Barak is right there, and my whole InStride research team that is really diverse and does lots of awesome things and wouldn't be able to do this work without them. So thank you. And on.
Great talk. And we have time for questions from the audience. Dr. Ram.
Thank you so much for coming. This is an amazing program, and I'm really impressed to see the big changes that have been made. Excited to see where it goes in the future too. I'd love to hear a little bit more. So you mentioned about 30% of people don't have a primary care doctor, but the other percentage does. What's been your approach to coordinating that care with someone's primary care doctor, like in that case that you showed?
Yeah, so the question was, there was 30% who did have a primary care provider in the last year, and then other individuals who did not, but also how did we coordinate with their known primary care providers? Is that right? Sorry, I couldn't hear all of it. So that was really important. So we talked to the providers that are in the area, including large FQHCs. And one of the things they said to us, their patients weren't getting medications, or the other thing is they could have issues with prior authorization or all these other things about getting their medications, right? We all know that. They really, we were able, one of the amazing things is the pharmacist actually communicates with the known clinician to ask, you know, is it okay? Would it be okay to switch? Maybe there's a cheaper medication, or they're actually helping with the financial navigation and actually helping patients overcome, and the providers, you know, overcome those authorizations and other things. But the other important thing is not that we're going in there to be their new provider, right? We had to do a lot of boots on the ground, but it might be linking or helping fill in a bridge or a gap that patient, you know, sometimes there's long waiting times to get to see you guys, right? And they can't wait. And then they go without their medications, and then you're like, you know, they're in the hospital and there's all these things. So could we help facilitate that? So yeah, it's a lot of communication.
Thank you, Dr. Springer. That was really exciting work. How much of this program is funded by grants? How much is funded by the health system? And if we had a situation where we didn't have grants and wanted to do something like this, what would a funding mechanism look like for that?
Yeah, no, and it's a great question because it's the thing that keeps me up every night. So this was all funded through this Big Idea grant, Director's Pioneer Award. So it is funded through a NIDA grant. The whole idea was to develop the protocol and then work with the model and then assess maybe parts of the model, or the whole model could be used in other settings. But importantly, also determining how this could be sustainable without grant funding. So that's one of the things I'm doing all the time and it's something that I'm learning is I'm not a businessy person. And so how you sell this to healthcare providers. So Yale New Haven Health System is pretty big, and they're trying to reach all of Connecticut. And there's a war with, you know, the other northern part, Trinity Health and Hartford Healthcare, and they want to expand. And so trying to talk to them about how this is a good idea. They already have their Yale pharmacy working with us, and that their pharmacy is getting revenue. So determining, showing them the data about how this could helpfully improve healthcare and reduce costs. So something similar was done. The Yale was starting to see increased emergency room use, and obviously there's a lot of cost to them for individuals who are at the Columbus housing shelter in New Haven. And the individuals who were there running the housing shelter gathered the data, went back to Yale and showed them, if you gave us, a APRN, we could probably reduce that. So they did that. And so they do respond to that data. So we are capturing that data and we're doing cost effectiveness as well. But no, that's a big thing. And it may not be this whole model, it might be aspects of it. So community health workers. So as we were talking at dinner last night and elsewhere, community health workers, and I think they are in Colorado too, are now going to be our billable services. So like, could community health outreach workers you do telehealth, or could you provide some part of an FTE of a clinician if that's what the community needs? And then now that retail pharmacies are legal, any pharmacy can be legal. So CVS and Walgreens and everybody are chomping at the bit. You know, you could improve access to healthcare through navigating all of these. But yeah, no, it's a big question, is sustainability.
I've got a question. As you evaluate this, Sandy, and you look at the, do you have a way of modeling or measuring the potential need and what portion of that this model meets in a geographic area?
That's what, yeah, we're trying to do. So working with the Department of Public Health, we just, you know, Josh was, and Greg Gonzalez were two individuals who, Greg at Yale School of Public Health, who does different aspect of that, but really talking to them about how we can improve modeling and predicting and getting data together. So we've started to do that, and then creating a real-time, the next step is real-time data dashboard where the data can be fed back to the communities of interest and those who might be providing funding decisions about what services are missing and what they need. But yeah, no, that's the geo-targeting idea and where we need to go. And it's not just like the town, you know, it's identifying which area of the town, who are the people, and then also gaining trust so it's a lot, and that's what we're doing. So New Haven actually just reached out to us. I didn't think they would need us because there's so many services, but they're finding that they have real-time data of where overdoses are happening on an hour by hour level, day of the week. And they said, we can't get people into clinic. We can't get the access to medications. Could you come? What if we partner together? We can show you where to go. Would you be able to come? And so we're seeing that more and more and so that's great because we could go back to Yale and show them too, right around the corner, you need help accessing services. So maybe they would help with this program.
I'll ask another. And related to that, do you have a way of modeling downstream cost avoidance as I wonder about social impact funding as a sustainable.
Yeah, so well, that's something that we're looking at. So one of the groups, Cherish, is helping with cost data, but it's really important. I don't everything we're trying to do at the same time, but that is an important thing we have to do. And if Josh wants to help with that too, that would be really good.
Volunteered for a few things. Thank you so much.
Thank you. Thanks for listening.